So the initial treatment for multiple myeloma, before you start anything, involves the determination of if the patient is eligible for a stem cell transplant or not. The treatment will usually involve a three-drug regimen, and that consists of an immunomodulatory drug, a proteasome inhibitor, or a monoclonal antibody, and a steroid. So you may have heard words like, VRD or CyBorD, KRD. Essentially, these are drugs like bortezomib or lenalidomide with a backbone of a steroid like dexamethasone. Newer drugs are things like carfilzomib, um, the monoclonal antibody daratumumab. So any of these drugs in this combination, usually a three-drug regimen, is going to be used regardless of if the person is going to first go, is going to end up going for transplant. What changes is the duration of the cycles. So if the person is going to go for transplant, they'll usually receive 3 to 4 cycles of this three-drug regimen, followed by stem cell collection. Once the stem cells are collected, they may receive the transplant at that point, or they continue with the three-drug regimen until first relapse, and then they would receive, the stem cell transplant. The decision about treatment choice is going to be personalized based on the patient's performance status, their comorbidities, their age, and of course, the patient's preference as well. So, although the backbone is a three-drug regimen, for an older patient, somebody with, really poor kidneys, whatever their issue is, it can be modified to a two-drug regimen or even a one-drug regimen. And then when it comes to things like relapse, we're looking at specific numbers on their blood work. We're looking at their M protein, we're looking at their kappa lambda. If somebody's numbers are initially going down or M protein is non-existent and all of a sudden starts coming up, obviously that's a relapse and we would need to switch therapy. We don't expose patients to drugs typically that they've already had before. And thankfully in the myeloma sphere, there are a lot of different drugs that allow us to do all these different combinations. So the treatment becomes really tailored to that particular patient there. So it's not a situation of, first relapse, you get X, second relapse, you get Y. It's what works for the patient, what have they seen before, and what is, the possible next step. So it's all going to be, subsequent treatment planning is going to be based on what they've already seen and what they can tolerate.